Welcome to the deep dive. We take your sources, unpack them, and really get to the core of the knowledge inside. Our mission today, giving you that shortcut to being truly well-informed about a pretty serious health issue in horses. Today, we're diving deep into equine right dorsal colitis, or RDC. It's something every horse owner, every enthusiast really should be aware of. We've got some great sources, comprehensive reviews, detailed vet texts. We're going to sort through it all. By the end of this, you'll understand not just what RDC is, but critically, why it happens, how it shows up, and how vets actually diagnose and manage it. There are some genuinely surprising things in here, some crucial insights that honestly could make a huge difference. Okay, let's get into it. So let's start right at the beginning. What exactly is right dorsal colitis? What's the basic problem?
Okay, so at its heart, right, dorsal colitis is an inflammation, an ulcerative inflammation, really localized to one specific spot in the horse's large intestine. That spot is the right dorsal colon. And what's really key here, I think, is its strong link to non-steroidal anti-inflammatory drugs, NSAIDs. Things like phenylbutazone, flunexin, things many owners use.
Right, common stuff.
Exactly. And another critical piece, dehydration. If a horse is dehydrated, it significantly bumps up the risk of this drug toxicity. It's a bad combination.
So it's an inflamed, ulcerated gut lining triggered by meds that seem pretty routine, but specifically in that one area. Why there? Why the right dorsal colon? What's special about it?
Yeah, that's a great question. And it's where anatomy and physiology kind of collide. The horse's large colon, I mean, it's huge, maybe 3.5 meters long, holds 50, 60 liters. It's vital for digesting fiber.
A big fermentation vat, essentially.
Yeah, pretty much.
Yeah.
Now, the right dorsal colon itself has this natural narrowing right before it connects to the next section, the transverse colon, sort of a bottleneck.
Oh, okay.
And things move slower there, too. The digestive transit time is slower. So you've got this constriction, slower movement. It means NSAIDs, especially bute, which can bind to feed and release later.
Oh, interesting.
They just have longer contact time with the gut lining right there, which intensifies the toxic effects. Plus, that area might just be more prone to reduced blood flow, ischemia, kind of a weak spot.
So it's like a slow-moving traffic jam in a narrow tunnel holding the drug right against the wall. It makes sense. But how do the NSAIDs actually do the damage, like at the cellular level?
Like getting into the mechanism, it really boils down to prostaglandins. These non-selective NSAIDs like bute and flunexin, they inhibit KEOX1 enzymes.
Gotcha.
And KEOX1's job is making protective prostaglandins. PGE2 is a key one. PGE2 is like the gut's bodyguard. It maintains the lining, keeps blood flowing, helps secrete bicarbonate to buffer acid.
So it keeps things healthy and protected.
Exactly. But when you inhibit KEOX1 with these NSAIDs, you lose those protective effects. The mucosa, the gut lining, becomes vulnerable. Bacteria can invade. Toxins can get absorbed from the gut. Plasma protein starts leaking out. And phenylbutazone specifically seems to reduce bicarbonate secretion right there too.
Yeah.
So it's taking away the protection and making the environment more acidic, more corrosive.
So it's not just the drug itself, but how it messes with the gut's own defenses in this already vulnerable spot. And then dehydration makes it even worse. Really is a perfect storm, isn't it?
That's a perfect way to describe it, yeah. The development of RDC is often this convergence. The NSAID making the lining fragile, the anatomy and physiology of that specific spot making it susceptible. And then you add stressors, dehydration. Even mild dehydration people might overlook. Intense training, certain diets, it all piles on.
What kind of diets?
Diets high in non-structural carbohydrates, like a lot of grain, or maybe diets lacking enough long-stem fiber. Those can also contribute to making that area more vulnerable.
Okay, so that leads us to what you actually see in the horse. What are the signs? And you mentioned it can vary a lot.
It really can vary dramatically,
Right.
which makes it tricky. You can have these acute, sometimes devastatingly fast cases, or much more subtle chronic problems.
Okay, so what does acute look like?
Acute can be peracute, meaning incredibly severe and rapid. You might see just relentless severe colic, profuse, watery diarrhea, sometimes with blood. Dehydration happens fast, progressing to endotoxic shock, maybe a fever that comes and goes.
Sounds terrifyingly fast.
It can be. In the worst cases, death can happen in just hours, sometimes before diarrhea even shows up, and the colitis is only found on postmortem.
Wow.
On exam, you'd see a very high heart rate, fast breathing, skin stays tented when you pinch it, cold legs and ears, and just profound depression. They're incredibly sick.
And the chronic form, you said that's more subtle.
Much more insidious, yeah. The signs creep up. Mild to moderate colic, but it keeps happening. Gradual weight loss, they seem lethargic, appetite's off, and often you'll see soft, maybe cow pie type manure. That's a common sign.
Okay.
And a really significant finding often is ventral edema. Swelling under the belly, maybe down the legs. That's from severe protein loss through that damaged gut wall.
Ah, the leaky gut letting protein escape.
Exactly. You might also notice teeth grinding, bruxism, or just subtle changes, like they're just not quite themselves, maybe picky about their feed. Little things that can be easy to miss.
That huge range from sudden crisis to just sort of off must make diagnosis really tough. What about the ripple effects? You mentioned protein loss, endotoxins. What else goes wrong systemically?
Yeah, the compromised gut barrier sets off a cascade. First, the lab work abnormalities, the clinical pathological stuff. The most consistent finding, the one we rely on diagnostically, is that marked low protein, low albumin in the blood. Hypoproteinemia, hypoalbuminemia, that's what causes the edema.
Right.
You might also see mild anemia, electrolyte imbalances, sodium, potassium, chloride, can be often elevated lactate, which points to tissues not getting enough oxygen.
Okay.
And their white blood cell count can be revealing too. Often it's low leukopenia, specifically low neutrophils, maybe with a left shift, meaning lots of immature cells being pushed out. That suggests the body's fighting a significant infection.
So the blood work tells a story of protein loss and inflammation or infection.
Definitely. And then you have the broader systemic complications. Bacteria and endotoxins leak across that damaged gut wall into the bloodstream. That causes endotoxemia, potentially leading to septicemia, which is a full-blown blood infection.
Very serious.
Very serious. And that endotoxemia can trigger other major problems, like laminitis, that devastating hoof inflammation. You can also see kidney problems, sometimes also from the NSAIDs themselves, clotting disorders, coagulopathies. And it's not uncommon to find ulcers elsewhere, too, mouth, esophagus, stomach, along with the RDC. In chronic cases, you can even get scarring in the colon, leading to impactions later on. It's a whole body problem originating in that one spot.
It really illustrates how interconnected everything is. So faced with all this complexity, how do vets actually start narrowing it down? What's the diagnostic process?
Getting a diagnosis quickly and accurately is just crucial. It always starts with a really thorough clinical evaluation. That means a detailed history, super important.
What kind of history?
Asking specifically about any NSAID use. What drug, what dose, how long was it given? Also recent diet changes, any stressful events, travel, intense work.
Okay, the context.
Exactly. Then a full physical exam. Checking for colic signs, assessing hydration very carefully, looking at mucous membrane color. Are they pale? Are they brick red or purple? Suggesting shock. And the character of the feces. Like we said, that fecal consistency going from normal to soft or watery, that's often the clearest, most easily monitored sign of ulceration for an owner or vet.
Makes sense. What about lab tests? You mentioned the low protein and inflammation signs. How reliable is that?
Blood work is critical, but interpreting it requires a bit of nuance. Yes, the complete blood count, the CBC, might show anemia or those inflammatory changes. The serum chemistry often shows that dramatic drop in protein and albumin and maybe low calcium too. Elevated lactate is common in the sicker horses.
But you said there's a nuance.
Yes, the real power is in serial assessment, checking it repeatedly. Because a horse that's acutely sick and dehydrated might initially have normal or even high protein levels on paper just because they're hemoconcentrated.
Ah, because they've lost water, so everything looks more concentrated.
Exactly. But as soon as you rehydrate them with IV fluids, those protein levels can plummet, revealing the true extent of the protein loss from the gut.
So one test isn't enough.
Usually not for the protein picture. Daily monitoring of packed cell volume, PCV, which measures red blood cells, and total plasma protein, TPP, is often recommended in the early stages. And then watching that protein and albumin gradually climb back up over weeks, maybe months, that's a key sign healing is actually happening. It takes a while, though, 2 to 12 weeks usually, to see significant improvement there.
Okay, so tracking the trends is key. Can you actually see the damage without surgery? What about imaging?
Yes, absolutely. Diagnostic imaging is huge here. Transabdominal ultrasound, looking through the body wall with an ultrasound probe, is really considered the gold standard for getting a presumptive diagnosis.
What do you see on ultrasound?
You're looking specifically at the wall of the right dorsal colon. In affected horses, it becomes characteristically thickened, significantly thicker. Healthy colon wall might be, less than half a centimeter thick. With RDC, you can see walls maybe 1.5 centimeters thick or even more. And often there's a very distinct dark hypoechoic layer within the wall, which represents edema, fluid swelling.
So you can literally see the inflammation.
You can see the thickening and the edema, yes.
Yeah.
And doing serial ultrasounds, repeating them over time, is incredibly valuable, not just for the initial diagnosis, but also to track how well the treatment is working. Seeing that wall thickness gradually decrease is a great sign.
Any other imaging?
Gastroscopy, putting a scope down into the stomach, is also usually recommended because, as I mentioned, concurrent gastric ulcers are pretty common in these horses. You want to know if they're dealing with ulcers in both places.
Right, treat the whole picture. So history, signs, the blood trends, the ultrasound, that gives you a strong presumptive diagnosis. What about a definitive 100% confirmed diagnosis?
Yeah, well, all those things together build a very strong case. The only way to get a truly definitive diagnosis is to actually see the lesions directly and get a tissue sample, a biopsy.
How do you do that?
That usually requires surgery, an exploratory laparotomy, where the abdomen is opened up, or sometimes laparoscopy, using keyhole surgery with a camera. You can then visualize the colon surface and take biopsies.
Is that done often?
It's generally reserved for cases where the diagnosis is still uncertain despite the other tests, or if complications like scarring are suspected, or if the horse isn't responding as expected to medical treatment. It's a bigger step.
Okay, so let's say you have the diagnosis, presumptive or definitive. What's the treatment plan? What do you do?
Management is really comprehensive. It has multiple parts. But the absolute first, most critical step, stop all NSAIDs immediately.
Number one priority, no question.
No question. If for some absolutely critical reason an NSAID is unavoidable for some other life-threatening condition, you might consider one of the more QX2 selective drugs, which are generally less harsh on the gut. But even then, you need extreme caution and monitoring. But the default is stop them all.
Makes total sense. Beyond stopping the trigger, what's the immediate supportive care, especially for those really sick, acute cases?
For the acute ones, aggressive supportive care is life-saving. Intravenous fluids, and lots of them, are crucial to correct the dehydration and electrolyte imbalances.
Pouring fluids in?
Pretty much. And if that protein level is dangerously low, causing significant edema, they'll need plasma transfusions or synthetic colloids. These help pull fluid back into the blood vessels by increasing what we call plasma oncotic pressure.
To counteract the leakiness.
Exactly. And pain management is key, but you can't use NSAIDs. So you rely on other classes of pain relief, like opioids with torphanol, for example. And minimizing stress is surprisingly important. Reduce their workload, keep them in a quiet, calm environment. Stress can definitely hinder healing.
And the diet. You mentioned diet was a factor. How central is it to treatment?
Oh, it's absolutely a cornerstone of treatment. Huge. The goal is to reduce the physical load and irritation on that damaged colon. Give it a chance to rest and heal.
How do you do that?
You transition them to a diet that's low in bulk, but highly digestible. Often this means a complete pelleted feed, frequently one based on alfalfa, which provides good quality protein and is easily broken down.
Pellets instead of hay.
Yes, and this is a big one. Long-stemmed hay, like regular grass or alfalfa hay, should be strictly restricted or, in many cases, completely eliminated for at least 3 months.
Wow, 3 months with no hay. That's huge for a horse.
It is a radical change, and it feels counterintuitive for many horse owners. But it's critical to minimize that mechanical irritation passing over the ulcerated areas. Think of it as letting a wound heal without constantly rubbing it.
Okay, minimal roughage.
Minimal roughage. Feed small meals frequently, maybe 4 to 6 times a day, to keep the digestive system working gently. Some supplements can help too. Psyllium mucilode, like Metamucil, can form a soothing gel and promote healing. Adding oil, like corn or safflower oil, maybe a cup a day, provides calories without bulk, and the fatty acids might help mucosal healing by encouraging the body's own prostaglandin production, the good ones.
Interesting. So the oil helps replace some protective factors.
Potentially, yes. And any dietary changes, especially when you eventually start reintroducing roughage way down the line, have to be incredibly slow and gradual, because full healing of that colon wall can take a long time. 3 to 6 months is typical.
That's a real commitment to careful management. Are there specific drugs beyond supportive care that target the gut itself?
Yes, there are. Misoprostol is one. It's a synthetic version of that protective prostaglandin PGE2 we talked about. It can help replace what the NSAIDs blocked and promote healing.
Does it work well?
It can be beneficial, yeah, but it can also be quite expensive, and sometimes it can cause mild colic itself, so you have to use it carefully. Sucralfate is another common one. It acts like a bandage, forming a protective layer over the ulcerated areas.
Like Pepto-Bismol for horses, kind of?
Sort of, but it physically coats the ulcers. Then there are drugs like metronidazole or sulfasalazine, which have anti-inflammatory effects specifically in the gut. Antibiotics might be used if there's evidence of a secondary bacterial infection, like sepsis, and anti-endotoxic therapies if endotoxemia is a major concern.
Lots of potential tools in the toolbox. What about surgery? You mentioned it for diagnosis sometimes. Is it ever a primary treatment?
It's generally not the primary treatment anymore. Medical management is definitely the preferred first-line approach today. Surgery is really reserved for specific, severe complications.
Like what?
Like if the chronic inflammation leads to so much scarring that it actually obstructs the colon, causing repeated impactions, or if a horse simply fails to respond to intensive, prolonged medical therapy.
And what does the surgery involve?
Typically, it involves removing the damaged section of the right dorsal colon and bypassing it, rerouting the digestive tract. It's a major surgery.
Sounds risky.
It is. The prognosis for horses needing surgery for RDC is generally guarded. There are significant risks: infection at the surgery site, complications from the bypass, all the usual risks of major colic surgery. Historically, when RDC was less understood, surgery was tried more often, but the outcomes weren't great. That's why there was a big shift towards intensive medical management first. Surgery is really a last resort now for when there's an anatomical problem like an obstruction, or the tissue damage is just too severe to heal medically.
Okay, so medical management is the main path. What's the long-term outlook then? If a horse gets through RDC, are they okay? Can it come back?
The prognosis is really variable. It ranges from guarded, especially in those severe acute cases, to good. A lot depends on how quickly it's recognized and how appropriately it's treated.
What factors suggest a poorer outlook?
Horses that present with very high heart rates, really high PCV indicating severe dehydration, abnormal mucous membrane colors suggesting shock, those generally have a tougher time. But a positive response to the initial treatment, seeing the clinical signs improve, the blood work start to normalize, the ultrasound showing the wall thinning, that's all favorable.
How long does recovery take?
Clinically, an acute case might start looking better within, say, 7 to 14 days with intensive care. But, as we've stressed, that complete healing of the colon wall takes much longer. 3 to 6 months is the standard time frame we think about for full recovery.
So you need ongoing monitoring for quite a while.
Absolutely. You need to keep monitoring for any recurrence of colic, tracking those serum protein and albumin levels, repeating ultrasounds periodically to watch the wall thickness, and monitoring their weight gain. It requires patience and diligence.
Which brings us to prevention. How do you stop this perfect storm from happening again, or in the first place?
Prevention really circles back to the main trigger, NSAIDs. It's all about extremely careful, judicious use. That means vets using the lowest effective dose for the absolute shortest time necessary.
Minimum effective dose, shortest duration.
Exactly. And implementing drug holidays, especially with drugs like bute. If a horse needs longer-term pain management, giving breaks allows the gut lining some recovery time.
What about the CHO-X2 selective ones? Are they safe long-term?
They're generally considered safer for the gut than the non-selective ones like bute, yes, but safer doesn't mean zero risk. Even with CHO-X2 selective NSAIDs, if they're used long-term, continuous monitoring is still really important. Vigilance is key.
And diet.
Continued careful dietary management is crucial too. Sticking to principles like low-bulk, highly digestible feeds, avoiding those spikes in non-structural carbohydrates, managing roughage intake carefully, especially if the horse has had RDC before.
And
Minimizing physiological stress where possible. Regular monitoring, checking those protein levels, maybe periodic ultrasounds, especially in horses that might need intermittent NSAID courses for other chronic issues like arthritis. It's about managing all those contributing factors proactively.
wow. That was definitely a deep dive. It's so clear that RDC is, well, complex. It's tied tightly to NSAIDs, obviously, but hinges so much on the individual horse, their gut anatomy, their diet, hydration, stress.
It really does.
But the encouraging part is that with prompt diagnosis, that multi-pronged medical approach, and really diligent long-term care, the outlook seems much better than it perhaps once was.
Indeed. And I think understanding RDC really highlights why it's so important to look beyond just the symptoms.
Yeah.
You have to understand the underlying mechanisms, the predisposing factors for that individual animal.
Yeah.
It underscores how vital critical thinking and understanding physiology are, especially when using common medications.
So for you listening, the takeaway seems to be vigilant, know the signs, both the dramatic and the subtle ones, and have those really thoughtful conversations with your vet about any NSAID use, about hydration, about diet. It's just such a powerful reminder of the science and the careful observation that goes into keeping these amazing animals healthy. And maybe something to think about for yourself. How might things change in the future? Could we see more targeted diagnostics, maybe even precision medicine, tailoring NSAID choices or doses based on a horse's individual genetic risk for pet issues? Where could that take us in managing conditions like RDC over the next decade? Definitely something to mull over. Thank you for joining us on The Deep Dive.